everybody to this EPI-WIN call. We decided to try and use a video, see if the internet holds. I have with me here today Rosamund Lewis, and I'll just have to squidge over to her. Thank you to everybody who's joined. We're going to talk about social and physical distancing on this call, and I do have a presentation, so I'm going to share my screen. If you're joining through a computer, you should be able to see the presentation. Let me start that now. Over to you, Rosamund.
Good afternoon, good morning, good evening, wherever you are. We are always very happy to talk with the health sector partners, our natural partners, of course, amongst the range of partners that we talk to. So today what we thought we would do is give a little primer on some of the public health measures that are being put in place by countries, and they go by different names: public health measures, social distancing measures, physical distancing, and we will just go through a few of those. But before we do that, we will just update on the current situation. So we're at 335,000 cases already confirmed, keeping in mind that a number of countries are now in a situation where not all cases are being tested, all suspected cases are being tested. But we're now with 190 countries, so we're approaching the asymptote of almost all countries. And unfortunately, we're counting now more than 15,000 deaths. The most affected countries, this is a chronological list. It's not a list of new cases appearing now. So China still has the most number of cases, but their curve has come down to, as you heard before last week, to virtually zero. I think there were zero locally acquired cases in 4 days in a row, but still having several tens or up to 100 imported cases from other countries. Italy is still possibly now approaching the peak of their epidemic with a very large number of cases. I think it's around 40,000, depending, given the size of the country compared to the population of China. And then you see the other countries there that are now coming up in terms of number of cases. The United States of America actually has really entered its very steep curve for this epidemic. This shows us the outbreak worldwide and a breakdown by the number of cases appearing daily in each region. So if you look where we started, we had a few cases in Wipro. This is March actually, so this is not from the very beginning, which is why the relative number of cases in the Western Pacific region, WHO, it's called the Western Pacific Regional Office. That region is already lower, whereas the European region was obviously taking off. And you can see that very clearly from the early March all the way through to the 21st of March, this week essentially. And now we're midweek, and what we're seeing is a dramatic rise in the number of cases from the AMRO region. That's the Americas Regional Office, also known as the PAHO, Pan American Health Organization Regional Office area, basically the Americas. That includes North America, Central America, and South America. So it's the Americas now that are entering the next phase. Basically, what we're seeing is that the pandemic is accelerating. It took 67 days from the first reported case to reach the first 100,000 cases. That, of course, was in the Western Pacific region. 11 days for the second 100,000 cases, and just 4 days for the third 100,000 cases. Over 1 billion people have now been asked to stay home in over 50 countries or territories, and that number is going up all the time. This morning, was it just this morning or yesterday morning, I heard it was Côte d'Ivoire and Senegal. But it changes, everything in this outbreak, and this pandemic changes so fast. We all struggle to keep up. So what are these public health measures, social distancing measures? Another term that's used and was specifically used for influenza. So for those of you who were involved in influenza planning, there's the term non-pharmaceutical interventions. It's not on this slide, but what did that mean was that for influenza, we actually have vaccines, or we can convert the vaccine production capacity to pandemic vaccine should we have an influenza pandemic, which was one of the things that was being planned for and on the horizon. And then there's also treatments, antivirals, already confirmed and approved antivirals for influenza. So because those public health measures were vaccines and treatment were available for influenza, then in the influenza world, we called everything else non-pharmaceutical interventions. Now for COVID-19, we actually don't have yet, as you all know, this is being worked on, we don't yet have vaccine or treatment. And so we're basically staying away from the non-pharmaceutical intervention language right now and just calling them public health and social distancing measures, because this is common terminology in the public health arena. So WHO has established kind of a framework for countries to plan through various aspects of the work that they're doing. You'll see in the left column of this particular table the scenarios. So we have 4 scenarios. A country or a subnational region may have no reported cases. I'm just going to flip through these quickly. The second one is 2 sporadic cases. So when countries are just importing or just detecting their first imported cases, or already detecting cases for which there's no travel history. The third scenario is clusters of cases. So when either a cluster of cases due to importation or one case may cause a cluster. And number 4, where there's community transmission. Now, this does not mean countrywide transmission. It does mean, though, that transmission is established at the community level from person to person, and it could be in a relatively small area, or it could be in a very large area, like the original, of course, was Wuhan with 11 million people. But we reserve that term for transmission in a local area. It does not necessarily mean nationwide transmission. So if we go back to the second column now, you'll see that there we have listed a number of public health and social distancing measures. And so I want to emphasize again that these may be considered for application at the local or national level. And what we're doing with this set of tables is basically just describing what is. WHO at this moment, at this time with you today, is not saying, these are all recommended, or these are good or bad, or introduce them at this time or that time. Right now, what we're just aiming to share with you is what are countries actually doing? What have they been doing? And what are some of the options that are out there that we can all learn from? Because as you know, we're all learning as we go along in this pandemic. So the first column is basically these public health and social distancing measures that are being applied. And again, it can be at different scenarios, but we've aligned them so that they're most commonly seen in the scenario where they're presented, but it doesn't mean that they have to be implemented in that time or space. The first one, though, that I do want to re-emphasize, as you've seen perhaps in the press conferences with our Director General, that the testing, contact tracing, quarantine, and isolation still remain the backbone of all interventions in all countries. That insofar as it's possible, insofar as resources allow, capacity and time allow, the testing, contact tracing, accompanied by the public health measures, the social distancing measures of quarantine and isolation, remain essential. Because even when you have community transmission on a broader scale, it will mean that as people, as populations, entire populations stay home, essentially, the number of new infections will decline. And so that will give the public health services, who are probably also working from home, the time to actually trace contacts of new cases. So the hardest time that it is to do that is when community transmission is being established and public health measures have not been brought in yet. But I spent a lot of time on this because I just really want to emphasize that if you have a role in testing and contact tracing, don't abandon that role. It's really important. The next set of measures we're looking at, or what you've been hearing already for 3 months, is the personal and family measures. Clean your hands, cough into your elbow, don't touch your face, and stay home if you're sick. That was supplemented then by no contact greetings. So, a little namaste, or a hand on the heart, or a nod, or just a wave. So basically no contact greeting, no shaking hands. Basically because we know that the virus transmits not only by droplets, but also by contact from person to person or from contaminated surfaces, and then you can transmit it to another person through a handshake. So that was the next thing. Physical distancing is what we've also been saying, which is basically keep, just like Sarah from me right here now. You can't see her on the screen, but she's right here because we're keeping a meter between us. And that's important as well, at least a meter. Some are saying 2 meters, so we just want to acknowledge that there are different takes on this, but what we're saying is at least a meter distance between any 2 people, even if you're not sick at this time, because now the pandemic is there and you don't know anyone next to you could be infected. So these were what we're calling personal and family measures, because you may be also in isolation or in quarantine with family members. Governments have been assessing risk for mass gatherings from the very beginning. One of the first things you may have heard about is that this big event was canceled, or discussing whether the Olympics will go ahead. And so these huge mass gatherings, big festivals, big conferences, big faith-based gatherings are some of the first, well, don't like to use the word casualty, but that's what I was about to say. Some of the first casualties of this epidemic, because they're the first to go. These are not only mass gatherings where many people are together, but people come from many different horizons as well, different countries, different areas. And so they were some of the first to go. So that's actually a really important clue that this is really, action is taking off in a country. Another thing that we saw right from the beginning is different border measures, screening, restrictions, bans, travel advice of different types. So not everything has to be a travel ban. It can also be screening people on arrival, which is about 50% effective because many people are already infected but don't have symptoms yet or don't have fever yet. But also, you know, some countries have put in, at least earlier on, it may have changed now, but earlier on they put in measures such as screening on arrival, or just basically saying, okay, you go straight into quarantine or straight into self-isolation on arrival. So if you really want to be here, by all means come, but if you're just coming for a 2-week holiday, then maybe there's not much point. But it was voluntary upon the traveler to make the decision to go or not. Other types of travel advice, educational institutions. So we started hearing about countries obviously closing. These are all measures that are well recognized and recommended for pandemic flu, for example. And most countries are building on their pandemic influenza preparedness plans. And so we're already ready to put in place many of these measures. We've talked about workplace preparedness a lot. Schools, educational institutions includes all the way from primary all the way up to university. But also health settings, which include health care, as well as long-term care and other forms of facilities. Public transit, basically some areas just cut public transit altogether. Some areas actually added more public transit so that people can have more distance between each other, that physical distancing. And of course, companies were putting in place business continuity plans and occupational health and safety measures, which are specific to health, you know, specific, well, I guess everyone, but also for health workers. So surge capacity, personal protective equipment, physical distancing in the workplace, and so on. We'll go through these briefly and come back to the third column later. So when a country is already having sporadic cases, all of the above measures that have been discussed should also be considered and many times put in place. So for example, adapting and canceling public events and private events as well, even those that may be smaller, including weddings, in some cases, things like that are very private and very important, but countries have asked their citizens to forfeit those for the time being or to make it a much smaller event. Voluntary physical distancing in schools, at work, and public transit, we've talked about those already. Shielding and protection for special groups. This is important because, as we already know, there are certain groups of people who are at much higher risk of serious illness. Everybody's at risk of infection. Let's get that one straight. But some are at higher risk of serious illness, and that includes anyone that has an underlying medical condition, or people who are older, even if they don't have an underlying medical condition. Also, folks who live in closed institutions, whether that be seniors residences or partially closed institutions, seniors residences, long-term care, psychiatric care, prisons. So many of these start limiting visitors and having stay-at-home measures for the vulnerable. For example, Britain already, several countries have asked their seniors to remain at home, even before bringing in other measures, they basically said, in order to protect yourself, just stay home. Have someone else drop your shopping off at the door. Educational institutions, and basically reducing any non-essential travel, not only externally, but also internally. So on this one, you're already having clusters of cases. It's basically more of the same, but if we could add on to that, what we were seeing is that places of worship were also closing or going on to teleservices. And this is hard for many people, having their usual ritual, their weekly ritual, or maybe, you know, other frequencies is really, really important. And I think it was probably one of the hardest things that our faith-based partners have had to do, is to tell their congregations that they could not hold their services. Now, restricting local movement is what has become obviously very visible worldwide. I said earlier that 1 billion people have now are now at home under stay-at-home orders. At first, this can be voluntary. At first, companies were jumping in and saying people could work from home, and even healthcare was initiating telemedicine strategies, anything that would prevent people from coming to a health unit if they didn't actually have to. So video consultations, telephone consultations, deferring non-urgent or health or medical care, many of those things have come in as measures. And then the most strict measures have been put in place by any number of countries. So here we are in Geneva at WHO headquarters, and we most folks are at home. The vast majority of staff are working from home. They're teleworking, and some live in France across the border and come into Switzerland, and some are just in Switzerland. And so we're all dealing with what are in fact strict stay-at-home orders. We don't like to use the word lockdown. Some do, because it's something easy to understand. But essentially, strict stay-at-home orders, and many countries are implementing that now in this most extraordinary of situations in this pandemic. During that time, of course, it's essential to reorient the health system to implement the health sector surge plan, because you've heard that hospitals will need more beds, more ventilators, more oxygen supply, more doctors and nurses, and in some cases, legislation has been brought in to support all those measures. So I see quite a number of people are already raising their hand for comment. I think I will go through the last column, because I want to make an important point that many of these measures are restricting. That's the whole point. They're designed to be restricting, because they're designed to ensure physical distance between individuals, but they're also designed to keep groups of people apart and to reduce density of population and reduce any opportunity for people to gather, whether it be in transit or entertainment or work or travel, any of those things. And these things bring hardship, and they can bring hardship in many different ways. We'll come back to the very end, but you've already heard countries that can afford it announcing multi-billion-dollar packages for economic support for people who can't work and things like that. So those are very large-scale national economic banking policies that are also important in this outbreak. But if we go back to our first scenario, where we still have no reported cases, there are many things that there's very few countries left in that situation now, but many things that countries have been doing to actually prepare. So one of the things that we did at WHO right from the very beginning was to develop a risk communications and community engagement plan. So this EPI-WIN, this whole thing that you're participating in right now, the WHO Health Information Network for Epidemics, is part of that. It's part of our risk communications engagement with you. But countries and local public health units and others have done that as well across the world, and it's really important in your language, in your culture, in your local context, to develop risk communication strategies that are appropriate for you at the local level. And some of the key messages there are to communicate what is risk, what does it mean, risk of infection, risk of serious illness, risk of hospitalization. People are very concerned for their children, they're concerned for their parents, and what are the actions that each and every person can take for self-protection. So this is a risk mitigation strategy in the sense that if people understand what's happening, then of course, ideally, the plan is that there should be less panic. You have probably heard that basically as the wave arrives in each country, people start to panic. And the role of risk communication is critically important at this early stage. Also at the early stage is already incentivizing stay-at-home measures. That would be for employers, for example, who would extend leave without pay, or extend teleworking policies, or extend contracts, anything that people can remain financially solvable and still stay at home. One of the big vectors of transmission in this epidemic has been that people need to continue going to work, and so it's really important for employers. It has been really important for employers, and many have initiate some of these incentives to allow people to stay home regardless of their income situation. Of course, the widespread availability of hand hygiene measures, this is especially important for well, all countries, but also lower and middle income countries with highly dense populations in certain areas where normally water points are not so widely available, sanitizer may not be so widely available. So already planning very early on to increase the number of water points, to make public facilities available wherever possible. Strengthening access to essential medicines, not only, as you know, there's no specific treatment for this coronavirus yet at this time, but people may have many other illnesses, whether it be insulin for diabetes, whether it be antimalarials, whether it be tuberculosis treatments, things that are critical for them to maintain their health, needing to have basically a minimum of a 2-week supply, and ideally longer for anyone who may find themselves in quarantine or isolation. It's really important to engage children in preparing, because I think most countries are going to find themselves in situations where the entire population is under a stay-at-home order. And it's really important to engage children thoughtfully, intelligently, with compassion, with humor, to understand what's going to happen, why they cannot go outside and play in the park, so that they are partners with you and with your families. For many of you who are in the health sector and are seeing patients, to engage with them early. Let them know that they should be talking with their children. Plan iterative assessment strategies. And so basically what this refers to, it's a bit of jargon, but what it refers to is that this is moving so fast, it's hard to stay on top of things. It's going to be the same everywhere, but don't let that deter you from actually, on a daily basis, rethinking, are you doing the right thing? You can change what you're doing, you can update it, you can adapt it, but don't think that because you put a plan in place today, it's going to be good tomorrow or next week, it may not be. So flexibility is really important. And preparing for a resurgence of cases, eventually, as measures are lifted. I've put this very early in this table so that you can see that we're already thinking about exit strategies, transition strategies, how to lift public health measures when the number of cases goes down. This will be important. So as we go through, for each one of these scenarios, and I won't read every single point, you can have these slides afterwards. So the point is really risk communication remains important. You've heard a lot about avoiding stigma. First it was avoiding stigmatizing Asian people, and then it was avoiding stigmatizing Italians and Iranians, and basically we're all in this together now. It doesn't matter who you are, who we are. We need to protect each other and support each other, and that avoidance of stigma still remains very, very critical. Engaging community, business, and religious leaders locally as well as nationally. More special support strategies for vulnerable groups. We've talked about income maintenance strategies to support adherence to public health measures. Now schools are interesting, because a lot of talk is about closing schools, but in fact a lot of schools haven't closed at all. What they've done is they've either physically closed the building, but put in place teleworking, teleschooling, I should say, teleschool and telestudy strategies. So whether it just be a system where students have homework that is assigned, if you're in a context where people don't have internet at home, or not enough of the students have internet at home, you can still plan, teachers can still plan a lesson plan for a month that they give to their classes, and have parents support the students to go through those lesson plans if at all possible. There are many ways of doing things. Also, schools are not always closing. Sometimes it's called school dismissal, when most of the students are sent home, but some of the staff and some of the administrators remain in the school for special reasons. And one of them, for example, one of our anecdotes here in Switzerland, but it's happening elsewhere as well, is that schools are actually open. Kids are at home, but schools are open because they're staying open for the children of health workers who need to go to work, anybody who cannot telework, and our critical frontline staff. So if you're in the health sector and you are going to need to work through this period, and you have young children and you don't have care plans for your young children, it's something to discuss with the schools, that they can stay home with skeleton staff for a few children, as long as they respect the hand hygiene, respiratory hygiene, and physical distancing methods that will keep the children from infecting each other, even in the school while they're there. And also, if they're children of health workers, making sure that the virus doesn't circulate from the health unit to the home and to the school. So these things need to be planned in advance and done very carefully, but it is possible to keep schools open for special groups. And of course, we have migrants, homeless, communities, NGOs, civil service-based organizations are also jumping in to support that work. So here, if you look at the fourth bullet point, I want to bring in a new element, which is implement community resilience and mental health strategies. You've heard already about mental health strategies and people being very mindful of how they're going to be coping when they're at home. We are all we're all social creatures. We're subject to stresses, including stress of not seeing family and friends. Where possible, there are now many ways in which we can communicate. It used to be just the good old telephone or the over the fence post, and now there's many video and other methods for communicating, even this type of format, which you can communicate with a very large group of people. You can still have your party, but everybody is in their own home, and you can still participate that way. So these mental health and social support strategies are really important, especially for people who live alone and especially for the elderly. And so community resilience strategies includes planning how to support people who live alone, or seniors particularly who live alone, having ways that are set up to make sure that everybody's checked on, receives a phone call, gets a shopping bag dropped off at the door, or whatever is needed in your local community. And so the teleworking and teleschooling plans can be tested well in advance. Maybe there's still time to acquire the technology that you need, even if it's acquired online, before some of these measures come into place. And in the last one, this is where we've brought in the sort of more macro, once countries are going into stay-at-home orders, this is a situation where clearly governments are in charge, whether it be national or local, and bring out the security services, the police, and all of that. And so it can be scary. Again, talking with kids is really important. But at that level, the important thing is to protect the food supply, and that has two elements. One is actual transport routes for the food supply, but also locally. So virtually all the examples we've seen, the grocery shops are open, and sometimes open early, so that elderly can shop first before other crowds arrive or other people arrive. Keeping pharmacies open, keeping clinics open, reorganizing your clinics so that anyone who may possibly be there because they think they may have COVID is oriented separately from anyone who comes there for their regular care for hypertension, diabetes, or other things that can't wait or can't be done through a video call or phone call. And at the macro level as well, economic impact it can be mitigated, and countries we're seeing are already doing this, offering economic relief packages for their citizens, for those who must stay at home but cannot continue working. And then the last piece we're not going to discuss right now, but I mentioned it at the very beginning, which is for each single one of these measures, it's going to be really important to assess carefully and withdraw the measures gradually. We will all be learning by doing in this as well, because China now is facing the situation. Singapore, to some extent, is facing the situation. Singapore never actually closed their schools. They used a different approach to keep their schools open and keep their population informed. But all of these measures will eventually have to come down. But at the same time, it opens up the risk of seeding new mini outbreaks or new cases, and so that will have to be addressed. That's a very long talk about about 4 slides, but I hope that has helped orient you to what are public health and social distancing measures, which results in keeping physical distance between all members of communities, and the strategies to support the implementation, to gain the trust of the population, to avert resistance to these measures, and to mitigate the risks of the negative consequences of the measures themselves. So there are some examples that we have from a couple of different countries of orders that have been put out by ministries of health. So the first one is Rwanda, and the second one is Togo. So again, it can be very, very simple. It doesn't have to be as complex as I've already illustrated to you through this presentation. Basically just public orders announcing unnecessary movements or visits are not permitted. Employees shall work from home wherever possible, border closures and travel things, and so on. So bars, restaurants are often the first ones to go, because that's where people congregate, obviously, to socialize. So these are examples of what some of these things can look like. We just want to give an example. This is just one, so we don't have others here, but this is France and what has happened in France, which shows you from late January. So when the very first case was reported to WHO on the 24th of January, and basically all along the bottom, it's mostly 0 cases. You have 1, 1, 1, 5, and these are importations. So people were traveling and they arrived and they were diagnosed, and those clusters were put to bed immediately, so to speak. But eventually, globally, as the epidemic began to take off, you see around the 2nd of March, suddenly a bump in the number of cases from 1 to 20, and then 40, and then 60, and then 100. And during that time is when the government started bringing in some of these measures. So already very early on, limiting public gatherings was done even while there was still less than 20 cases per day. These are daily counts. Yeah. So some of these things, I say that's one of the first things you'll notice right away, is that this is a strategy that's brought in by governments very quickly. And so you can see that economic measures were announced when there was just 285 cases. So the government did, in fact, react quite quickly in the early stages. Now, there's one thing you really need to keep in mind, epidemiologically speaking, is that from the time a case is detected or somebody tests positive, then they have to go through their incubation period, which we say is up to 14 days, but in fact the median is about 5 to 6 days. And then from the time that someone gets ill, then it takes another 5 to 6 days for them to manifest more serious illness before they may actually show up at a request to be assessed at a health unit. So we're looking at 2 weeks, 10 days to 2 weeks, from when someone becomes infected to when they actually become ill enough to be really identified as a case of serious illness. And so everything you see on these epi curves is basically you need to say this reflects the infections that happened 2 weeks ago. So even if we look at where we are today, you see the graphs there for France is 1,800 cases per day. That's a lot. But this reflects the infections that took place 2 weeks ago. So what we're doing now with everyone staying at home, everyone's under a stay-at-home order. There's still public transport, but restaurants are closed. Schools are telestudying, teleschooling, and all those measures. In fact, we're going to see the impact of those in a week's time. They started a week ago. We're going to see the benefit of those in a week's time. So that's why our Director General has been saying, and Dr. Mike Ryan have been saying, you need to get in there and you need to get in early. It's early action that's going to make the difference in the number of cases for this outbreak. Okay, thanks very much. Over to you, Sarah.
Thank you so much, Rosamond. I'm going to stop sharing the screen now, just because we want to move over to some Q&As. And I'll also stop my video, because otherwise you will see a very close-up picture of my face the entire time while I read the questions. So I'd like to just say that thank you to everybody who has submitted questions on the calls last week as well. We are in the process of finalizing that Q&A, and we will put it up on our website. So thank you for your patience with that. Which leads me to another point. The EPI-WIN team have just launched their new website, and you can find that at www.who.int/EPI-WIN. And on this web page, you will find dedicated sections, sort of serving as a one-stop shop for the different audiences. So there is a health sector section on the website that will have all the resources, and that is hopefully where we will be able to put up the Q&As that we gather from these calls. So thank you again for your patience while we work out all these systems of trying to capture and feedback the information to you. So we're going to go through some of the questions now. Marianne is asking, the proportion of infected COVID-19 who are healthcare professionals is worrying. Italy and Spain report numbers like 8 to 12%. Will WHO start to look into this and maybe come up with some statements? Now, I know I have Catherine Kane on the line. Catherine, can you raise your hand and I will promote you to a panelist so that you can answer some of these questions? Because Catherine is from our Health Workforce Department. Right, Catherine should be ready to go.
Great, thanks, Sarah. We are noting the questions with regard to health worker infections. From the earliest days of this outbreak, we have been extremely active with the WHO Health Emergencies Department, and specifically with the infection prevention and control colleagues, as well as with the data and surveillance colleagues, with regard to not only collecting this data, because while that is important and helps with external advocacy, there are two more important elements of this data, and we will send a link to the mask guidance in just a moment. With regard to the health worker infection data, it's what it tells us that's really critical. One is the need for personal protective equipment of a variety of uses. And the second is where there needs to be an intervention in order to correct perhaps misuse or overuse or reuse of personal protective equipment. So where supervisors need to be doing greater surveillance of health workers during their practice, where additional training is needed to ensure that health workers are using the correct PPE and using it properly. What the goal of this data isn't for data purposes, for the purposes of having those numbers, but truly to understand where infection is happening, where we can stop infection, and where additional supplies and equipment are needed. And we use that data straight up the line to continue to advocate heavily. It does not exist. We do have, as we've promoted on this call, a health worker exposure risk assessment tool, which we will re-highlight to you. And we highly encourage you with that in your facility levels and within your ministries of health to encourage the use of the tool and the aggregation of that data in order to make timely, quick, and effective interventions to prevent health workers from becoming dead heroes, but rather let's keep them as live heroes who are on the job, to ensure that we keep as many health workers as possible out of quarantine where they cannot be effective in caring for people. So all of these are very, very important. There is not a global data collection during an emergency. It's one of the most challenging. I can say this as an emergency professional of over 20 years. Getting data is one of the most challenging things to do at the national level, at the subnational level, because while you're working on emergency, your focus is caring for people or doing the appropriate planning and getting the supplies. So we are certainly encouraging this consistent focus on data as it informs decision making, and we are continuing to advocate at the very highest levels for effective guidance on personal protective equipment, for guidance on how it is being adapted to local contexts, for advocacy with private businesses manufacturers and nations with regard to their stockpiles and with regard to how we can encourage safe production of necessary supplies that meet certification standards and prevent further infections. So we are advocating and talking at the very highest levels on multiple fronts on all of these issues. And if my colleague Ivan Ivanov is also here, he can speak to our discussion groups, our briefings, our statements, our expert convening, all on occupational safety and health. But with regard to the numbers, we don't have them. Believe me, we would love to have them. I just got off a call with our regional colleagues wherein we discuss this as well, and we have regional focal points and be working with countries to collect the data. Sorry for the long-winded reply, but it is absolutely critical to us. With regard to the N95 masks, there was some confusion 2 days ago, which it's important to address, which is that which is the discussion of what aerosolized means. Now, while droplets that come from a symptomatic individual are in the air, they can only be transmitted approximately 1 meter, where potentially they could land on surfaces. But when I cough, my cough droplets don't go 3 meters across the room. So when we talk about aerosolized droplets, what we're talking about is when a healthcare professional opens up the throat of a person who is symptomatic, which releases a lot more of droplets. And that's when you're looking at the N95s and the FFP2.
Catherine, we lost you for a minute there.
Okay, so just to reiterate, that's where we're looking
yeah.
for the higher level of PPE, like the N95s and the FFP2s. That said, it remains critical that those who have contact with symptomatic and potentially symptomatic general populations for extended periods of time should know correct use of medical masks. Now, with regard to, sorry, I just saw this, with regard to swabs, I will refer that question to our IPC colleagues, but that is a non-aerosolized generating procedure to the best of my knowledge. I would highly recommend that you remain in close contact with your public health authorities to follow the guidance that they are providing at the national and sub-national level. And the EPI-WIN site, especially this new launch, with many congratulations to the EPI-WIN team for an extensive amount of work, has just launched the new portal. There is a specific area for health workers, and we continue to link with the latest infection prevention and control guidance that is officially available from the WHO. We also, yes, of course, we recommend mass testing. If you listen to our Director General, we say test, 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 test. That's how we know how the virus is active in the population, spreading and affecting symptoms of people. So we are doing our very best to keep the most active information available for you on the EPI-WIN site. We will be pushing out when there is new information, and we continue to be very, very appreciative of the inputs and recommendations that you have been giving to us that allow us to highlight key concerns and use on-the-ground examples of where additional guidance is necessary, of where additional supplies are necessary, and of where additional support is necessary. Thanks, and back to the panels, please.
Thank you so much, Catherine. Really privileged to have such a passionate person working on this area. There is a question about whether or not COVID-19 is treated as an occupational disease when a health worker contracts it. Ivan, over to you, you're on the line.
Good afternoon, everybody. Do you hear me? Yes. Okay.
Yes.
Thank you very much. My name is Ivan Ivanov, and I'm responsible for occupational health in WHO. Clearly, WHO has identified in the document on the rights of health workers in occupational health and safety that COVID-19 should be considered as an occupational disease. Infections among healthcare workers should be considered as an occupational disease. many countries, actually 70% of the workforce worldwide, have some form access for social protection of occupational diseases, including financial compensation. And they have schemes for reporting of occupational diseases. So it is very important, first of all, to have a good investigation of the cause of the COVID-19 infection, whether it is predominantly from the workplace or it is predominantly from the community or from home. And this is where the WHO tool for assessment of exposure of health workers to COVID-19 is extremely important. So if it is an infection and if it is already a disease, not only a contact and quarantine, but if there is a disease, then the disease has to be reported by the employer to the national authority that is dealing with the compensation of occupational diseases and injuries. For example, in Italy, this is the Institute for Social Security in ISLE. In France, it is the social protection. So there in the different countries, there are different mechanisms for reporting of these diseases. And there might be also the social protection schemes may decide different also thresholds for the reporting of such diseases. But this is extremely important that at least the diseases are reported and notified to the appropriate authorities as occupational diseases. Whether they will be compensated and how much will be compensated, that's a separate story. But we need to put together also at the country level measures for tracking of these notifications of COVID-19 cases as occupational diseases, distinguishing by also sectors and groups. Most of them will be from the health sector, but we don't exclude also COVID-19 occupational exposure and occupational diseases reported from other sectors. Over.
Thank you so much, Ivan. I think we'll move on to a couple more questions. We have a question with regards to Dr. Agarwal has brought up the symptom of anosmia. Rosamond, perhaps you want to talk about that.
Sure. So anosmia is the loss of the sense of smell. And this symptom has been reported now from several locations, from Italy, but also from France and also from China. Now that China is less busy with they no longer have serious illness cases, they can spend more time looking at the data that they collected in the early stages. So some things have come out from our Italian colleagues, which was the hyperemia, conjunctival hyperemia, which is basically red eyes, conjunctivitis of sorts, and also loss of sense of smell and loss of sense of taste. These are interesting and very mild symptoms, and it seems that children may also have these symptoms. And so again, this just emphasizes that many people may have the infection and have very mild manifestations, and that this is why these public health measures that we're discussing today are not only important but also effective, because otherwise people move up and down without even realizing that they may already have the infection and symptoms, but may not attribute those mild symptoms to this particular virus. So this is why in this particular, with this particular pathogen and this particular outbreak, public health measures are critically important, actually.
Thank you, Rosamond. We have a question from Shager. Perhaps I'm saying your name incorrectly, but to keep nurses informed, can WHO develop a kind of e-online training through the nurses' organizations in different countries? COVID-19 is a new concept and we need to be skilled on it. What do you think? So we do have some trainings already online. Catherine, do you want to say anything more about that?
I am so sorry. I'm not seeing the question. Could you repeat it for me to make sure that I answer it correctly?
Sure. It's about training nurses through the nurse organizations in different countries. What do we think? An e-online training, and I mentioned that we do have.
Well, actually, I would be delighted to answer this question in 3 parts, which is kind of the way I go about things. First, we are extremely closely with global nursing organizations and we'll be doing 3 briefings directly for those organizations later this week as we, number 2, lead up to World Health Day, which is focused on the contributions of nurses and midwives during Year of the Nurse and the Midwife, and when we will also highlight data on nurses and midwives in countries around the world, and emphasize the need for more and more training and more resources. And number 3, with the WHO Academy, we are working very rapidly on scaling up a training, particularly on infection prevention and control, and a number of other areas to offer very fast training to healthcare professionals. And while this is a work in progress, we hope to have more information quite soon on how to support national and subnational efforts to offer high quality, quick, on-demand training.
Thank you, Catherine. We have a question about South Africa. For a country like South Africa, not yet locked down, however, yesterday in the evening, the president announced that some measures will be starting this week. What may happen to such a populated country with the people? What are the risks? Rosamund, do you have any comments on that?
Thank you. So this is what WHO and all member states are grappling with at the moment, is as the cases begin to appear in countries in Africa and other lower middle income countries. So we are very aware of a number of things. First of all, about public health measures. A number of countries have already started. You're indicating that that South Africa will start this week. It's important for the population to respect and understand this. I do believe that humanity is very resilient. Communities are resilient. And it's in times of crisis that people become creative and even more resilient. And it's really important that, that people receive the information that they need in a transparent manner to manage their own risk and to comply with the public health measures. You're thinking probably this is going to be very difficult in a densely populated area, and that's probably true. But at the same time, if people do manage to stay, we're talking about, of course, there are others who may not have homes, that's another problem. But if people do manage to stay within their homes and things that are very difficult culturally, but need to be respected, which is staying home, very simple, just stay home. Number 2 is basically don't have any visitors, and especially don't visit your elders at this time. It's culturally, for all cultures actually, extremely difficult to accept that kind of message. Use technology to communicate and connect through video, through telephone with the people who are more vulnerable. And it's important that we keep the roads open and that we allow essential services to pass and essential personnel, nurses, doctors, health workers, frontline staff, police officers, to do the work that they need to do in as calm and serene a manner as possible. So I would like to just encourage you that we do think this is possible. There are a number of factors that we can add to this. For example, although the population of many African countries is younger than the European population, people may think we're not going to be affected. That may not be true. The population is younger, and therefore overall there may be fewer cases on that score, on the score of age overall, but the seniors will still be at risk and they still need to be protected. Secondly, there are other illnesses that you're well familiar with, which we don't know yet how they're going to interact with the coronavirus. So we're talking malaria, tuberculosis, sickle cell anemia. These are all conditions which may actually also, in addition to diabetes, hypertension, lung disease, heart disease, may also have an impact, and we have yet to see how that's going to manifest. So it's really important for people to a safe way, clear messages. There are many ways that this can be done. So you've got radio, it doesn't have to be through technology. Everyone has a radio, some people have a television. Of course, you don't want community gatherings, that needs to be avoided, but there's still ways of passing the message. Thanks.
Thank you. Aware we're almost at the hour, but there's quite a pertinent comment here from Mark. The stay-at-home programs take a large toll on fitness, mental health, increased loneliness. During the stay-at-home program, could people be allowed to go outdoors to exercise individually for, say, an hour? What is the risk of contagion if people would do this? So I think we're seeing different countries implementing different measures. I think for France, you can actually go outside for up to an hour as long as it's within 1 kilometer of your home. I think Italy had certain restrictions. And alone. In Switzerland, we're still at the stage where we have to be no more than 5 people, but still with a 2-meter distance between people. So there are different measures being implemented by different countries, but totally agree with you, Mark, that if you can be outdoors, if you can exercise, this is going to make a large difference. I do know we've been following on YouTube and a lot of online fitness classes now being offered for free across various activities. I even saw a report of a gentleman who had his treadmill on his balcony and ran a whole marathon on his balcony on his treadmill. So I think people are being extremely creative and inventive and trying to be sure that they access resources to stay fit, to stay sane, and to keep connected with people through different technologies. I think we're at the hour. We will take the rest of the questions and feed them into the Q&A. Thank you for your patience. I'll just ask my colleagues around me if they have any further comments to make. Rosamund?
No, I just want to say I encourage all of you. You're going to be, many of you are already in this, and some of you will just be starting now. Remain calm, remain serene. We are learning as we go along, but we've already learned a lot from the countries that are already going through it. I think if it's possible to encourage your communities to also remain calm and serene and address these risks as they arise and address the public health measures as they're implemented by nations and by communities. We will all get through this, and it will be difficult for some, and we hope that our communities can support those who find it more difficult. Thank you.
Thank you. Catherine, Ivan, anything you'd like to add? Ivan, carry on.
Yes, this is Ivan. There is evidence coming from China. I have seen several articles that one of the major actually causes of infection among healthcare workers is the contact with other healthcare workers. So social distancing should apply, physical distancing, not social, physical distancing should apply also to the healthcare facilities and the healthcare workers themselves, because there can be a transmission between healthcare workers. Thank you.
Yes, and if I could just add one more point to that, we also have a document from which we will be sharing messages with you about physical distancing within the family and the family measures. So if someone is under self-isolation, or someone is under quarantine, or someone is a health worker and still coming home to their family, there are ways, there are tips, there are tricks, there are things you can do to keep your home safe as well. And you really need to be very mindful and thoughtful about that, and have a family plan and discussion so that everybody understands what's happening and why.
Thank you. Catherine, any last comments? You're on mute, but anyway, we can come back to you. I'd just like to say that I will share the slides afterwards to everybody who registered for the call. I'll share the recording too. We'll collect the questions, feed them into the Q&A, and then really we're going to continue doing these as long as people want them. If you'd like to feed back into and suggest a topic area for the webinars, please do this as well. We're happy to meet the need and of the community out there. So please do feedback. Thank you everybody for your time.